Between 1969 and 1972, a group of colleagues and I gained admission to psychiatric hospitals by faking a single symptom, which was that we said that we heard voices, and the voices said, empty, dull, thud. The moment we were admitted to the hospital, we abandoned our symptom, and we behaved the way we usually behave. The question was, would anyone detect that we were sane? The answer was, no. No one ever did. Admitted with the diagnosis in the main of paranoid schizophrenia, we were discharged with the diagnosis of paranoid schizophrenia in remission.
If sanity and insanity exist, how shall we know them? That is the question that led to David Rosenhan being admitted into a mental hospital. In the early 1970s, David Rosenhan decided to test how well psychiatrists were able to distinguish the sane from the insane. Psychiatry as a field is, of course, predicated on the belief that its own professionals know how to reliably diagnose aberrant mental conditions and to make judgments based on those diagnoses about a person's social suitability, performance as a parent, parolees, flight risk, prisoner's ability to be reformed. Rosenhan was conscious and critical of the huge amount of social control psychiatrists had, and so he devised an experiment to test whether their actual skills were on par with their power. He recruited 8 other people, and together they faked their way into various mental institutions, and then, once in the ward, they acted completely normally. The goal? To see whether psychiatrists will detect their sanity, or whether psychiatrists' judgments will be clouded by presuppositions. If sanity and insanity exist, how shall we know them? The question is neither capricious nor itself insane. However much we might be personally convinced that we can tell the normal from the abnormal, the evidence is simply not compelling. It is commonplace, for example, to read about murder trials in which eminent psychiatrists for the defense are contradicted by equally eminent psychiatrists for the prosecution regarding the defendant's sanity. More generally, there are a great deal of conflicting data on the reliability, utility, and the meaning of such terms as sanity, insanity, mental illness, and schizophrenia. Benedict suggested that normality and abnormality are not universal, but is viewed as normal in one culture might be seen as quite aberrant in another. Thus, notions of normality and abnormality may not be quite as accurate as people believe they are. To raise the question about normality and abnormality is in no way to question the fact that some behaviors are deviant or odd. Murder and hallucinations are deviant. Nor does raising such questions deny the personal anguish often associated with mental illness. Anxiety, depression, and psychological suffering exist. But normality and abnormality, sanity and insanity, and the diagnoses which flow from them may be less substantive than many believe them to be. At its heart, the question of whether the sane can be distinguished from the insane, and whether degrees of insanity can be distinguished from each other, is a simple one. Do the salient characteristics that lead to diagnosis reside in the patients themselves, or the environments and contexts in which observers find them? The 8 pseudo-patients comprised a psychology graduate student in his 20s, 3 psychologists, a pediatrician, a psychiatrist, a painter, and a housewife, 3 women and 5 men. All use pseudonames in case their alleged diagnosis embarrassed them later. Those in the mental health professions claimed other occupations in order to avoid special attentions which might be accorded by staff as a matter of courtesy or caution to ailing colleagues. In order to generalize findings, admissions into a variety of hospitals were sought. The 12 hospitals in the sample were located in 5 different states on the East and West Coasts. After calling the hospital for an appointment, the pseudo-patients arrived at the admissions office complaining that they had been hearing voices. Asked what the voices said, they replied that they were often unclear, but as far as they could tell, they said empty, hollow, and thud. Those voices were unfamiliar and were of the same sex as the pseudo-patients. These symptoms were chosen partly because of their apparent similarity to existential symptoms, which are alleged to arise from painful concerns about the perceived meaningfulness of one's life, and partly because the absence of a single report of existential psychosis in literature. Beyond alleging the symptoms and falsifying name, vocation, and employment, no other alterations of person, history, or circumstances were made. The significant events of life history, relationships with parents and siblings, spouse and children, work colleagues, and people at school were described as they were or had been. Frustrations and upsets were described along with joys and satisfactions. If anything, these facts should have strongly biased the subsequent result in favor of detecting sanity, since none of their histories or current behaviors was seriously pathological in any way. Immediately upon admission to the psychiatric ward, the pseudo-patients stopped simulating any symptoms of abnormality. In some cases, there was a brief period of mild nervousness, since none really believed that they would be admitted so easily. Indeed, the shared fear was that they would be immediately exposed as frauds and greatly embarrassed. Many had never visited a psychiatric ward before, so their nervousness was quite appropriate to the novelty of the hospital setting and abated rapidly. Apart from this short-lived nervousness, the pseudo-patients behaved normally on the ward, speaking to patients and staff as they might ordinarily. Because there's uncommonly little to do on a psychiatric ward, they tried to engage others in conversation. When asked by staff how they were feeling, they indicated that they were fine and no longer experienced symptoms. They responded to instructions from attendants, to calls for medications, which was not swallowed, and to dining hall instructions. Beyond the activities that were available on their admissions ward, they spent their time writing down observations about the ward, its patients, and staff. Initially, this was done secretly, but it soon became clear that no one much cared, so it was subsequently done quite openly in such public places as the day room. The pseudo-patient, very much as a true psychiatric patient, entered the hospital with no foreknowledge of when he would be discharged. Each was told that he would have to get out by his own devices, essentially by convincing the staff that he was sane. The psychological stresses associated with hospitalization were considerable, and all but one of the pseudo-patients wished to be discharged almost immediately after admissions. They were, therefore, motivated not only to behave sanely, but to be paragons of cooperation. Nursing reports obtained from most of them all indicate that they were friendly, cooperative, and exhibited no abnormal indications. Despite their public show of sanity, the pseudo-patients were never detected. Except in one case, they were admitted with a diagnosis of schizophrenia and discharged with a diagnosis of schizophrenia in remission. The label in remission in no way indicates that the pseudo-patient had been suspected of simulating mental illness. Indeed, the evidence is rather strong that once labeled schizophrenic, the label stuck, so that if he was to be discharged, he must naturally be in remission, not sane, nor, in the institution's view, had he ever been sane. Although there were considerable variations between the hospitals, several were considered excellent. Length of hospitalization ranged from 7 to 52 days, an average of 19 days, so there was plenty of opportunity for them to be carefully observed, although in fact they were not. Pseudo-patients' daily visitors could detect no serious behavioral consequences of hospitalization, nor could the patients. Indeed, it was quite common for patients to detect their sanity. During the first 3 hospitalizations, when accurate accounts were kept, 35 out of 118 patients on the admissions ward voiced their suspicions, some vigorously. "You're not crazy. You're a journalist or a professor," referring to the continual note-taking. "You're checking up on the hospital." While most of the patients were reassured by the pseudo-patient's insistence that he had been sick before he came in, but was fine now, some continued to believe that he was sane throughout the hospitalization. So, are the patients better at detecting normality than the psychiatrist? Perhaps doctors are strongly biased towards type 2 errors, i.e., they are more inclined to call a healthy person sick, false positive, than a sick person healthy, false negative. It is clearly more dangerous to misdiagnose illness than health, so it is better to err on the side of caution. However, what holds for medicine does not hold equally well for psychiatry. Medical illnesses, while unfortunate, are not usually pejorative, but psychiatric diagnoses carry with them personal, legal, and social stigmas. Beyond the tendency to call the healthy sick, a tendency which accounts better for diagnostic behavior on admission than after a lengthy period of exposure, the data indicates the massive role of labeling in psychiatric assessment. Having been labeled schizophrenic, there is nothing the pseudo-patient can do to remove it, and it profoundly colors others' perceptions of him and his behavior. These findings are consistent with Gestalt philosophy's emphasis on the meaning given to elements by the context in which they occur, and with Asch's 1946 findings that they are powerful central personality traits which markedly color the meaning of other information when forming an impression of another person. Insane, schizophrenic, manic depressive, and crazy are probably some of the most powerful of such central traits. Indeed, many of the pseudo-patients' normal behaviors were entirely overlooked or profoundly misinterpreted. As far as I can determine, diagnoses were in no way affected by the relative health of the circumstances of a pseudo-patient's life. Rather, the reverse occurred. The perception of the circumstances was shaped entirely by the diagnosis. Nursing records for 3 pseudo-patients indicate that the writing was seen as an aspect of their pathological behavior. Quote, patient engages in writing behavior, unquote, was a daily nursing comment on the pseudo-patient who was never questioned about his writings. Given that the patient is in a hospital, he must be psychologically disturbed, and given that he is disturbed, continuous writing must be a behavioral manifestation of that disturbance, perhaps a subset of compulsive behaviors sometimes correlated with schizophrenia. Rosenhan's experiment elegantly explores the way the world is always wrapped by the lens we are looking through.